Welcome everyone to HIV Grand Rounds. Today I have the great pleasure of introducing Dr. Gabe Chamie and Dr. Gustavo Velásquez. Dr. Chamie and Dr. Velásquez are both faculty in our division here of HIV ID and Global Medicine. Dr. Chamie is an associate professor of medicine and Dr. Velásquez is an assistant professor of medicine. They are both phenomenal infectious disease physicians who see patients in our TB clinic here at San Francisco General, and they're coming here today to share cases from our clinic. Their talk is called Consuming Cases, Managing Complexities in Tuberculosis and HIV. So please help me welcome them. Thank you so much for talking today.
Okay, hi everybody. Thank you for the opportunity to speak. So I'm Gustavo Velásquez, and we're just going to get started with the case. So first, just a quick disclosure, I will be discussing off-label use of LTBI treatment today. So I've also changed some patient details for their privacy. So this is a 54-year-old male who presented to the Ward 94 tuberculosis clinic, who is from Eastern Europe, and he's living with HIV, and he's referred specifically for a positive quantiferon test. He had HIV that was diagnosed in 2006. His nadir CD4 was 162 and 12%. At the time, his viral load was 47,000. His genotype was wild type, and he doesn't have any known OIs. I don't know what his original ART regimen was, but after dolutegravir was approved, circa 2013, he went on dolutegravir with ABC and 3TC. He was HLA-B5701 negative. He's had excellent adherence, and you can see in December 2023, his viral load was less than 30, and his CD4 was 714. He also has diabetes. He has chronic transaminitis and hepatic steatosis, with ALT that ranges in the 80s to 120s and AST in 30s to 50s. He also has alcohol use disorder and has had several presentations to the ED and the hospital for acute pancreatitis last in 2023. And subsequent to that, he consumes less alcohol, but still does. And he also has hypertension, gout, and is a former smoker. For his medications, besides his ART, he's on allopurinol for his gout, atorvastatin, metformin for diabetes. He's on lisinopril and thiamine as well. He's allergic to sulfa, and social-wise, he does not smoke. He still drinks, I mentioned, 1 to 3 drinks a week, still trying to cut down significantly in the last several years. No IDU. He lives with his wife, has sex with women only, and no history was captured about his risk factors for acquiring HIV. He does have a history of prior exposure to active TB in his 30s. And as far as his review systems, just to mention, he has a negative symptom screen for tuberculosis, really quite asymptomatic coming into TB clinic. Vitals as well. I'm not going to go through all the details, but just to say vitals were normal and stable, and his exam was completely unremarkable, notably clear lungs as well. As far as his labs, so his CBC and his basic metabolic panel were unremarkable. His CD4 and viral load I've mentioned. He does have this chronic transaminitis, so his ALT was 120, AST 51, no cholestasis, and he had this positive quantiferon that was resulted in December 2023, and that prompted the presentation a couple months later to TB clinic. And as far as serologies for Hep B and C, he tested negative. And here's his X-ray, which was read as a normal X-ray, clear lungs, no pleural effusion, no abnormalities really. So just to warm us up, and get you kind of into the letter salad, word salad for TB treatment. So this patient has an indication for treatment of latent TB because he has a positive quantiferon, negative X-ray, negative symptom screen. He does have this chronic transaminitis that complicates the choice of his regimen. So which regimen on the screen has the least risk of hepatotoxicity in general? So I just advanced one time, is that right? Okay. All right, so the options are 1 HP, which is daily isoniazid rifapentine for 1 month, 3 HP, which is weekly for 3 months, 3 HR is daily of isoniazid rifampin for 3 months, 4R is daily rifampin, and then 6 or 9 months of isoniazid. That's what all those stand for. Okay, so we're getting a couple more votes. I'll just wait a second. So right now we're tied for 3HP and 4R. I want to see that untied perhaps before we move forward. Okay, all right, so it seems like 4R. Okay, so I think that's right, and I'll tell you why, but I'm going to come back to this. I'm just going to take a quick detour just to tell you about tuberculosis. And this is really a slide that I show pretty much every time I speak about TB, but I think we don't shout it from the rooftops enough, which is just how much burden there is in the world for tuberculosis. Just the fact that a quarter of the world is infected is staggering enough, but we've lost ground since the COVID pandemic. So now there's more cases than there used to be every year. It remains one of the leading causes of death, and especially among people living with HIV, it's one of the leading causes of death. So our job is to try to prevent it and treat it as much as possible. So there's 3 preferred regimens broadly for treatment of latent TB, and those are, as mentioned, 3HP, 4R, and 3HR, those first 3 rows. The previous gold standard treatment, which was isoniazid monotherapy, those have now become, since 2020 CDC guidelines have now become alternative regimens, because 4 months of rifampin daily was shown to be, in a large clinical trial, shown to be safer, and people were more likely to complete it, and it had non-inferior efficacy. There's also one regimen that isn't in the CDC guidelines, which is 1HP, and it was on that multiple choice list. And it's 1 month of daily isoniazid and rifapentine. This was brought forward by the Brief TB, the ACTG A5279 trial, which was a phase 3 non-inferiority randomized trial, comparing 1HP to 9 months of isoniazid. It was done exclusively in people living with HIV in areas of high tuberculosis prevalence, and it enrolled about 3,000 participants. The primary endpoint was development of TB and follow-up, and that was about 2% in both arms. But it's worth noting that only about 2/3 of the study population actually were confirmed to be or tested negative for latent TB. So the entire study population wasn't actually confirmed to have TB, latent TB. They were just living in very high-risk areas and happened to have HIV. So for that reason, DHHS has endorsed it, but you can see that there's a bit of controversy because CDC and the National Tuberculosis Controllers Association have not endorsed this. So there's a bit of difference of opinion, and I think this just summarizes the situation for people living with HIV, which is that we have 2 preferred regimens, 3HP and 3HR, but everything else is alternate, and that includes the isoniazid and rifampin monotherapy as well as 1HP. And then I put the quote there from the CDC guidelines. It's, as mentioned, because it was performed, that study was performed largely in people living with HIV who were not confirmed to have latent TB infection. And the other challenge with these these regimens is that that there's many drug-drug interactions with ART that, of course, people are taking if they live with HIV, and that can be challenging to work around, as well as, in particular, drug access to rifapentine around the world is challenging. Going back to the answer to the question, most people answered rifampin for 4 months was the one that was associated with least hepatotoxicity. I believe that's right. It's not been head-to-head compared against 1HP, but I have 2 figures just to walk through this. So might not be able to see here we go, see the mouse. So in the CDC guidelines, there was a network meta-analysis of the regimens that were all benchmarked against each other with a referent of this hypothetical situation of getting no treatment. And you can see that the odds for hepatotoxicity during treatment for LTBI with 3 to 4 months of rifampin given daily was the lowest compared to all the other available regimens. In this list, 1HP, the 1 month rifapentine isoniazid regimen, was not included, and it may be included in future guidelines. But I've just highlighted this here at the bottom from the New England Journal paper that did publish on 1HP, which is that in that large trial, among 1,500 people, there were 28 cases of severe hepatotoxicity with 1HP, and 42 with 9 months of isoniazid. And contrast that with rifampin. On the left-hand side, 4 months of rifampin, there were only 8 cases of severe hepatotoxicity around almost 3,000 participants for 0.3% risk, compared to 1.8% risk with isoniazid for 9 months. So numerically, I would say rifampin for 4 months is the one that's shown to have the lowest point estimate for hepatotoxicity. So for this particular person that came to clinic, there's also the complicating factor of their ART and the fact that they had chronic transaminitis. So then we asked ourselves, right, what other treatments are available that perhaps might be off-label for treating latent TB in this specific situation, which is somebody who actually has a very high risk of hepatotoxicity. And I think everyone knows that isoniazid, rifampin, rifapentine, all of them can be hepatotoxic regimens. So here's one idea. So there was a clinical trial called VQuin. It was done by the Vietnam Sydney Institute, and this is Gregory Fox, who presented it in November 2023 at the large TB conference, the Union World Conference. This was a trial that compared 6 months of daily levofloxacin versus 6 months of placebo for a context of people who had MDR TB. So this was MDR LTBI. And there were only 3 cases of confirmed TB in the levofloxacin group and 9 in placebo. So it was protective in this analysis. And so much so, in fact, I put that on the left-hand side of the slide, that in February of this year, the World Health Organization just went ahead and issued a rapid communication saying that if you have somebody with MDR LTBI, you can go ahead and use 6 months of levofloxacin. So I didn't put it in this slide, but just to say there was 1 severe hepatotoxic event in the levofloxacin group and 0 in the placebo group. So, levofloxacin technically could be hepatotoxic, but is generally not so. So it's just an idea for how you might treat somebody who has baseline transaminitis. But it would, of course, be very off-label because the indication is MDR LTBI. Then the other question that came up in clinic, and the reason why the clinic was consulted, was this question about what about rifabutin, and what do we know about that? So rifabutin is another rifamycin, so related to rifapentine and rifampin. It is not recommended for treatment of latent TB by CDC or DHHS or the World Health Organization. I've quoted here what DHHS says because they went out of their way to mention it in their guidelines, to say that rifabutin monotherapy is not recommended because DHHS actually does not recommend the use of 4 months of rifampin either in people living with HIV, because that regimen has not really been studied in people living with HIV. And also it's complicated because of ART drug-drug interactions. The National Tuberculosis Controllers Association guidelines are a bit softer on this, and they say, in cases where with expert opinion, an expert consultation, you might consider using rifabutin to replace rifampin for some people. And then this slide is we've shown before at Grand Rounds, Gabe and I, when we've done these presentations, and we brought it back to show you some of the advantages and disadvantages of these rifamycins next to each other. So rifabutin has a different profile of the enzymes that it induces in terms of its metabolism. And so it has a slightly different set of profile for the drugs that it interacts with. You can see that the patient was on ABC and 3TC, so all the rifamycins would be okay with that component of Triumec. But dolutegravir interacts with rifampin, and it would require BID dosing. For rifabutin, it could stay unchanged. You could just do once daily dolutegravir if you gave rifabutin, and same for rifapentine regimens as well. And the ones that have only been studied with dolutegravir so far are the preventive regimens, not the treatment active TB regimens that include rifapentine. And then I think one advantage, which doesn't apply in this case, but it's just worth mentioning, is that rifabutin can be used with ritonavir boosted PIs, not cobicistat boosted PIs. So that is another option, and it can be given at a dose of 150 once daily when it's used for treatment of TB. So going back to the case, now this was a complex decision. TB clinic was consulted, and there's a couple of things in the air. First, we want to avoid hepatotoxicity. Second, we want to avoid drug-drug interactions with ART. And third, the patient came in and said that he would really prefer to stay on his current ART, which is dolutegravir and ABC-3TC. So given what I've presented so far, which regimen would you choose? What I did is that I removed 6H, since we try to avoid that if we can, 6 months of isoniazid, and I put on the list as possibilities of 4 months of rifabutin instead of rifampin as off-label, or 6 months of levofloxacin as off-label. So what do people think? Okay, I think it's clear. All right, so people want to go off-label and give 4 months of rifabutin. I'll say, yeah, my initial reaction when I heard this case was I said, well, what about 6 months of levofloxacin? But actually, no. In fact, when he wasn't seen by me in clinic, but the recommendation was to give rifabutin 300 daily for 4 months. That way, the patient could keep their current ART. And then this schema of LFT and CBC monitoring was recommended, which is just to be careful about potentially, since the patient already had baseline transaminitis, just to watch it very closely and check LFTs at baseline 2-4 weeks and then monthly thereafter. And then because of the possibility of anemia and leukopenia with rifabutin, to check CBC at baseline at 1 month. Unfortunately, this was in February and the patient has had a very rough year. He has gout and has had several bouts of the gout, and so much so that his toe, where he gets the gout, got infected. Toenail had to be removed. He's just been kind of not ready to start treatment for LTBI yet. But the TB clinic and his team are in touch with him, and hopefully he can start it this year. So last, I just wanted to round out this discussion about rifabutin, just to give a few more pearls about it. So you can see all the rifamycins really look very similar. They really differ based on the side chain at the bottom right. Butane for the butyl group, right, 4 carbons, and pentene for cyclopentyl group, it's in the bottom right. They differ in terms of their properties. So even in clinical trials where these things are studied, rifampin is given without food because food decreases its absorption. Rifapentine is given with food, and specifically fat, because it actually increases the absorption quite a bit. Rifabutin is in the middle. It can be given with either food or no food. Because these drugs are usually given in combination with other hepatotoxic drugs, it's really hard to find good sources of data that tell you exactly for that particular drug how hepatotoxic is it. But LiverTox puts their coin down, and you can see that rifampin seems to be associated with minor ALT, AST elevations a little bit more than the other two. The adverse events are quite similar across all of them because they are all rifamycins, and it's hard to list them all in a single slide. But the properties of rifabutin that are worth mentioning are that neutropenia, leukopenia, and this very rare dose-dependent uveitis is a unique feature of rifabutin that you have to watch out for. Rifapentine in the trials where it's been studied, those regimens have also had some excess hypersensitivity and rash sometimes. So worth keeping an eye out if people are on rifapentine-based regimens. Drug-drug interactions are kind of legion for rifamycins, but for rifabutin in particular, use with opioids, benzos, and as we mentioned, some ARVs, it can be used in a different way than the others. And then at the bottom, I just summarized for latent TB, there's approved regimens that include rifampin and rifapentine. There's none for latent TB, but the guidelines for active TB do say that rifabutin can be used instead of rifampin, especially when there's drug-drug interactions, and there are approved regimens for rifapentine as well. So I'm going to be very quick about this because I just want to give you, I guess, a glimpse of the future. So right now it's hard to navigate all these drug-drug interactions for latent TB, but I think that there's going to be 2 trials to keep an eye out for latent TB that I think will be better for people living with HIV in particular. Phoenix, ACTG 5300B, is a randomized trial that is comparing among contacts of people who have MDR-TB, randomizing them 1-to-1 to either receive isoniazid with B6 or delaminid, which is a nitramidazole, so similar to metronidazole. This is a trial that have kind of older enrollment data at the very bottom. It is close to completion, we hope. but has just been quite delayed in accruing all the participants. And delaminid doesn't have a lot of ARV drug-drug interactions, so this would potentially be a win. And then Breach TB is a trial that's in development through the Smart for TB Consortium, which is funded by USAID, that I'm very lucky to be a part of, and I'm part of the protocol team for Breach. The lead investigators are at Hopkins, and this is a phase 3 trial that will actually do two things. Among contacts with MDR-TB, it will randomize people to either receive 4 weeks of bedaquiline or the now standard of care 6 weeks of levofloxacin that I mentioned from the VQuint trial. And in people who are living with HIV or have contacts with drug-susceptible TB, they'll get the same intervention, so a pan-preventive regimen of 4 weeks of bedaquiline or the 1 HP or 3 HP regimens, non-inferiority design. So so we're really looking forward to getting this trial started, and it's exciting. So all right, so I think with that, I'll just finish by saying 4 months of rifampin is probably the least hepatotoxic regimen. 1 HP is close. Preferred regimens for TPT in people living with HIV are not 4R or 1 HP. They're 3 HP and 3 HR. And there is some controversy around the 1 HP in particular. It's endorsed by some, but not all guidelines groups. And there's lots of drug-drug interactions to keep an eye out for. Rifabutin is not officially recommended. It's off-label use. Like in this case, with expert consultation, it was recommended for this particular patient. And future regimens hopefully will be not just include people living with HIV in the trials, but also will potentially be better with less drug-drug interactions. So, so that's it. I'll pass it off to you, Gabe. Thank you.
All right, good morning, everyone. It's nice to see you all. It's just this, my height. All right. Let's see. Okay, thank you, Gustavo. And so just by way of disclosures, I do receive grant funding from the NIH and from USAID, but no other financial disclosures. Okay. So I just wanted to quickly build off of Gustavo's case. This is a bit of a busy slide, but I want to walk through it. And point to a recent randomized control trial that I was a co-PI with Judy Hahn, pictured here, and with Ugandan co-PIs of Winnie Muindike at MUST in Mbarara, Uganda, and Moses Kamya at Makerere University in Kampala, Uganda, where we, sorry, seeing a hand raised here, we were asking this specific question of dealing with comorbidities of really heavy alcohol use, HIV and TB, latent TB infection. And this is something just as strategy-wise, I know Aisha is in here, is looking at this as well, of thinking of ways to use incentives in the form of contingency management to deal with treatment of people who are on stimulants and HIV and look at more than one outcome. So I just thought I'd share these results as recently published data from our division and our collaborations with colleagues in Uganda. And our overall objective was to determine if we could use or evaluate conditional financial incentives to reduce alcohol use while promoting isoniazid preventive therapy adherence in Uganda. As a side note, I know we just went through a whole range of options for latent TB infection and TB preventive therapy, but in much of the world, isoniazid monotherapy remains the drug of choice for people living with HIV in terms of availability. We're seeing more 3-HP or isoniazid and rifapentine now, but there's still some big issues with drug-drug interactions with available forms of antiretroviral therapy. So the study population we enrolled were adults living with HIV who had confirmed latent TB co-infection by skin test and had hazardous alcohol use, all in Uganda. It was multi-site in both rural and urban areas. And we randomized in a 2x2 factorial trial shown here, where one arm received control, one arm received a specific alcohol intervention I'll discuss, one arm received a INH adherence intervention, and one arm, arm 4, received both alcohol and INH combined intervention. And the interventions were these escalating incentives that were contingent on urine dip tests that were obtained at the time of routine INH drug refills when people would come to clinic to get their INH. And they would either get one intervention is the alcohol intervention if they had a negative urine dip test for alcohol. And this is ethyl glucuronide, which is a biomarker metabolite of ethanol. If that was negative, indicating no recent alcohol use, they would receive an incentive. The INH adherence intervention used an INH urine dip that was the isoscreen, which is a metabolite of isoniazid. And if that was positive for isoniazid, they'd also receive an incentive. And this is based on the idea of contingency management or incentivizing essentially the lack of substance use, in this case, alcohol. Fairly novel in that we did a pragmatic design where contingency management typically involves 2 to 3 time visits a week. And this was spaced out per month. So really try to meet the needs of people who are in resource limited settings and are not able to come to clinic for a whole variety of cost reasons with that frequency. The primary outcomes we were interested in were non-hazardous alcohol use at both 3 and 6 months. And this is a 6-month course of isoniazid. And we used a biomarker that is called PEth, which is a past month biomarker. So both at 3 and 6 months, they had to have a PEth that was negative. This is a fairly stringent cutoff. So really one of abstinence from alcohol and self-reporting no alcohol use. So this is an audit C negative. And just to show for the alcohol objective, what we were comparing then is arm 1 and 3 were the control, meaning no alcohol intervention, versus arms 2 and 4, where there was incentives for no recent alcohol use. Then the INH adherence intervention was more than 90% pill bottle opening by MEMS caps, which are remote monitoring. This is a comparison then of arms 1 and 2 of the control versus arms 3 and 4, where there was an INH intervention. And just the takeaway is that we saw a significant drop in a fairly stringent biomarker proven outcome of non-hazardous alcohol use, where the intervention had abstinence or no alcohol use at 17.6%. So higher meaning less alcohol use compared to the control at 9.9% for an overall risk difference of 7.6%. We saw no difference in INH adherence. We enrolled patients who were well established in HIV care and saw fairly high rates of adherence overall, although not 100%, and saw no significant difference in hepatotoxicity. Although interestingly, in the arm that we saw point estimates that were lower in those who received the alcohol intervention. But in any case, this our conclusion was that escalating conditional financial incentives led to significantly lower biomarker confirmed alcohol use, but had no impact on INH adherence. And this is something we're now considering putting in grant funding for to look at in TB treatment, where you're combining INH and pyrazinamide, which along with rifampin, so really 3 hepatotoxic drugs in people with heavy alcohol use, and HIV, which is a good proportion of people living with HIV worldwide. Okay. I'll move on to a case now. So this is our second case. This is a 41-year-old man who recently immigrated to the US from China with untreated chronic hepatitis B. It was known. His hep B DNA was 3 million. He's a 15-pack year history of smoking cigarettes, prior injection drug use, but has not used over 8 years. And he presented to his primary care provider for an initial clinic visit with a chief complaint of neck masses. Following an intake visit with his primary and some baseline labs, based on the neck masses, he was referred to otolaryngology to evaluate this bilateral lymphadenopathy that the PCP noticed on exam. So the primary care provider, on the way to making the referral to otolaryngology, took a series of baseline labs in this first encounter. The CBC is shown here was notable for anemia. Chemistry panel notable for some low, so hypokalemia, elevated creatinine, low vitamin D, and low calcium. And the LFTs were notable for a small increase in AST, low albumin. Hep B he was known to have, as I mentioned, is Hep B antigen positive and DNA 3 million. Hep C reactive, but reported prior treatment, and also hepatitis D antibody reactive. His ferritin was elevated, ESR was over 100, and his quantiferon gold was positive. So he was prior to the otolaryngology clinic, along with these labs, the primary ordered a neck CT scan. And that's shown here. And I think as you can see, what sticks out, and the cursor showing, are really these diffuse cervical lymphadenitis, lymphadenopathy bilaterally, that was read as concerning for metastatic disease. This multicystic conglomerate lesions also within the left parotid gland that may represent a primary tumor, though there's recommendation for further evaluation with direct tissue sampling. The read also noticed, just incidentally, that there's a limited view of the lung apices, but there's this right apical scarring with some adjacent central lobular nodules that could represent an infectious or inflammatory etiology. So otolaryngology then saw him and noted that the cervical lymph nodes had been present for about 2 months, according to the patient. And they had arisen briskly, but then had slowly decreased in size over time. But the patient was also complaining of now 2 months of associated fatigue. He'd lost about 5 pounds unintentionally. His past medical shown here I've already really gone through. His Hep D viral load, for what it's worth, came back undetectable. He had received Hep C treatment, as I mentioned, which may have also treated his Hep D. He was not on any medications, and he had no known drug allergies. Otolaryngology noted that he had diffuse cervical lymphadenopathy and exam, was concerning for underlying metastatic disease. And they went ahead and performed a flexible fiber optic laryngoscopy and an ultrasound-guided FNA of one of the cervical lymph nodes that was prominent. So just to briefly walk through, I'm not going to ask the audience to weigh in on what they think this is, because we're at a TB talk and I've done that before and it's 100% TB. So just a reminder that infectious causes do include mycobacteria, both Mycobacterium TB complex and NTM, less commonly, of course, and then endemic mycoses, which we do see often looking a lot like TB, but including cocci and histo in particular, and cryptococcus. Bartonella and syphilis can do this more rarely. Non-infectious causes, of course, must be considered and include lymphoma as well as metastatic head and neck cancers. Like in this case, based on the imaging, the supposition was that this is a parotid cancer with spread to the lymph nodes. We also see other lymphoproliferative disorders, including multicentric Castleman's in people with HIV, Kikuchi disease, sarcoidosis, and more rare etiologies like chronic granulomatous disease. So the lymph node pathology returned, and the path report said overall the findings are those of necrotizing granulomas. They note that the differential diagnosis is broad and includes what we just discussed, as well as an inflammatory reaction adjacent to a malignancy or cyst rupture. And they recommended excision because, again, an FNA is often non-diagnostic and excisional lymph node biopsy would be next. They also recommended collection materials for culture. Over the ensuing week, they followed up by phone, and the patient was now complaining of fever, night sweats, losing appetite, worsening weight loss. And with these FNA results, otolaryngology appropriately referred to our SFGH ID clinic. Fantastic to have this service available, led by Vivek Jain and Karina Marquez. The ID clinician responding to the referral said, "This is really worrisome for active TB." And they recommended masking the patient for respiratory isolation, getting a chest X-ray, getting sputum for AFB smear culture and expert, and HIV testing, all of which were needed and were done. So this person was diagnosed with HIV. The antibody antigen is reactive. Viral load is over 10 million, CD4 count of 92, 22%, and a chest X-ray was obtained. So this is the chest X-ray, and it was read and appears completely normal. But sputa were then obtained, and he was AFB smear positive. His expert was positive without RIF resistance, rifampin resistance detected. He grew MTB from the sputum within about 2 to 3 weeks. And his repeat cervical lymph node FNA was sent for AFB smear and MTB culture, and he was AFB smear positive from the lymph node as well as culture positive. It returned pan-susceptible. A chest CT was obtained by the TB clinic, and it showed the right apical linear scarring that we had seen on the neck CT with multiple nodules that are calcified. And then a little hard to see on this shown here, but hopefully you guys can make out with this resolution, but he had diffuse bilateral micronodules, all less than, I think that should be a centimeter, but less than a millimeter throughout, likely to represent disseminated disease, including tuberculosis. So just a quick note, these are older data, but from some work early in my fellowship, working with Diane Havlier and Edwin Charlebois and others, colleagues in Uganda, where we looked at patients with culture-confirmed pulmonary TB living with HIV, and we're looked at the range of clinical presentations. So these are all people with growing TB from their sputum. They have confirmed TB. And we saw, as you can see here, as with patients presented with lower CD4 counts, over a fifth were presenting with normal chest X-ray. And also cavitary lung disease, which many of us look for and think of in tuberculosis, became increasingly less common with advanced HIV. So lower CD4 count at time of TB diagnosis is clearly associated with a greater likelihood of a normal chest X-ray. We often use chest X-ray to rule out, but just want to highlight this is a case of someone with advanced HIV, the sputum positive by smear, who had a completely normal X-ray. There's also a lower likelihood of cavitary disease, as I mentioned. So All right, so the patient went on to get an abdominal pelvic CT scan as well, given his hepatitis B co-infection with HIV. He has cirrhosis with evidence of sequelae of portal hypertension, moderate splenomegaly with numerous subcentimeter splenic hypodensities that are consistent with splenic abscesses. I'm just saying in this context of someone with confirmed TB, this is almost certainly splenic TB. All right, so our diagnosis is pulmonary and extrapulmonary TB. This is miliary TB with dissemination to the spleen and the lymph nodes in a patient newly diagnosed with advanced HIV and AIDS with chronic Hep B, radiographic evidence of cirrhosis, and chronic kidney disease. So just a word on epidemiology of HIV, Hep B, and TB in China. This is, I think, in immigrants in San Francisco, one of our largest groups of immigrants. So just to note, China, in terms of TB, and this is the World Global TB Report from 2023, is among countries that are represented as high burden countries for both TB in general, that's this red highlight, MDR, or multi-drug resistant and rifampin resistant TB, which is the blue, as well as TB and HIV. Other countries are shown here, such as South Africa, DRC, and India. China is also has the greatest number of people living with hepatitis B. And there's a WHO Global Hepatitis Report from this year that notes that 10 countries shown here account for nearly 2/3 of the global burden of hepatitis B and C. And then just as a note also on key populations in China, referring to, this is from the UN AIDS report from 2023, overall, among people who inject drugs, the HIV prevalence is about 4.2%. And I just want to highlight that HIV testing and status awareness, though, among people who inject drugs in China is only at about 53%. And this really fits with this patient's presentation who purportedly was unaware of his HIV status upon seeking care in San Francisco. And a word about miliary TB. So miliary TB results from hematogenous spread of MTB bacilli. It's derived from the Latin word miliarius, referring to the millet seed. Just a reminder where that comes from. These are millet seeds, and this is an appearance on path. And it really referred to the appearance on gross pathology, as well as radiography. And it's due to spread from either a pulmonary or an extrapulmonary nidus of TB disease with embolization to the vascular beds of various organs. And the most commonly affected organs are the spleen, we see here, liver and lungs, bone marrow, kidneys, and adrenal glands. And this can occur at the time of primary TB infection when someone is initially infected, particularly children, infants, or as reactivation disease, meaning prior infection, latency, and then reactivation of TB. In the pre-antibiotic era, it was really common in infants and children, or more common than in adults, but now it's really more common in those with advanced immune suppression. And for people with HIV, that's really CD4 count less than 200. The clinical presentation is tough. It can be non-specific, such as in this patient with really B symptoms, lymphadenitis, constitutional symptoms, and symptoms and signs that really relate to the site of organ involvement. And just as a note, the antibiotic choice and duration really matches that of pulmonary TB if there's no CNS or bony involvement. Okay, so I've presented a fair amount of data. I just want to turn now to a first audience response question. So what TB treatment regimen would you offer this patient? He's pan-susceptible active TB disease, but HIV as well, chronic hepatitis B, and cirrhosis. So your options are isoniazid, rifampin, pyrazinamide, and ethambutol, or RIPE. This is first-line therapy in most patients, right, for 6 months. Option 2 is lose the pyrazinamide, go with INH, RIF, and ethambutol for 9 months. Option 3 is drop the isoniazid and the pyrazinamide and the rifampin and go with rifabutin, EMB, and levofloxacin for 9 months. There's an option of the 4-month regimen, which is isoniazid, rifapentine, PZA, and moxie. Go with entirely different MDR treatment regimen of BPAL-M or something else. Great. It's good to see a spread. I'm noticing fellows in here will be sitting in TB clinic, hopefully, sometime. So good to think this through. Okay. All right, I'm going to move forward. But yeah, I think this is a very reasonable choice and is what the clinic chose. One could try isoniazid, RIF, and EMB, and we'll talk about it. But certainly a concern would be increased risk of hepatotoxicity. So How do I move forward? There it is. Okay, thank you. All right, so just a word on treatment of, we'll talk about treatment of TB and with patients with liver disease, but just a word on specifically treating TB in Hep B co-infected patients. So there was a systematic review from 2022 in the Journal of Viral Hepatitis and meta-analysis that looked at the risk of hepatotoxicity with first-line drug-sensitive TB treatment. These are patients without cirrhosis. So this is, we know in cirrhotic disease, patients have higher risk of hepatotoxicity, but in those without cirrhosis with TB disease, and they compared those with versus without Hep B. And the prevalence of drug-induced liver injury, and this is DILI, was double in people who had Hep B without cirrhosis compared to those without Hep B. And the overall relative risk is shown here at about 2. There was also a retrospective cohort from CID in 2020 in Hong Kong that looked at TB, Hep B co-infected patients in public hospitals over 16 years. And patients who came in to the time of TB diagnosis and were already on Hep B antiviral therapy had a lower risk of hospitalization due to drug-induced liver injury compared to those who were not on Hep B treatment. So those significantly lower if you were on Hep B treatment. Interestingly, those who started Hep B antiviral therapy within a year of TB diagnosis were at higher risk of DILI than those who were already on Hep B treatment, presumably due to some inflammation from initiating treatment. And just the key points are that in patients like this, we're seeing even if their AST appears relatively, just barely above the limit of detection, you want to have a high concern for risk of liver disease because the risk of drug-induced liver injuries can be significantly higher in TB Hep B co-infection. And just to highlight that routine screening for Hep B and Hep C, something we do in Ward 94 TB clinic, as well as HIV, which we also do, are key components of TB care. So what about TB treatment in patients with underlying liver disease? So IDSA and ATS guidelines recommend selecting anti-TB medication regimens that have a lower risk of hepatotoxicity in those with advanced liver disease, cirrhosis, or an ALT that's greater than 3 times the upper limit of normal, that's not thought to be due to TB. So if someone has hepatic TB disease, yeah, go ahead. Sure.
The question was about whether the patient's cirrhosis, was compensated and whether that would compensate or uncompensated.
Great question. Yeah, so his liver disease was compensated. And like, as I mentioned, his MELD NA was 7. So overall, compensated liver disease, as I shared in that Hep B TB co-infection without cirrhosis, there is still an increased risk of drug-induced liver injury. But yes, you could consider in this case a trial of more hepatotoxic drugs and not going immediately to a completely INH PZA sparing regimen. And in fact, this patient actually did initially receive HRZE or RIPE, but didn't tolerate the PZA, developed rash and itching. I won't go through all the reintroduction that went on, and also had some drug-induced liver injury from the INH. So ultimately couldn't receive that regimen, and fairly quickly was transitioned to rifabutin, ethambutol, and levofloxacin due to tolerability. But great question from the audience. I just want to, well, I'll go through the guidelines and a word about really the beautiful monitoring that happens at Ward 94, the TB clinic, in patients like this. So the alternatives in liver disease, I just want to highlight that are listed in the most recent drug-sensitive TB guidelines by Pai and Mahid here at UCSF in CID in 2016 from IDSA and ATS, are you can choose treatment without pyrazinamide, a known hepatotoxic drug, and that would be 2 months of isoniazid, rifampin, and ethambutol. And you want to know this is drug-sensitive TB, by the way. And then 7 months of INH and RIF. So this is a 9-month option. The guidelines say to use 12 to 18 months of rifampin or rifabutin with EMB and a fluoroquinolone. They also mentioned drugs we're not typically turning to, like injectable amikacin, for example, or cycloserine. But anyway, with the option shown here, we often will use 9 months of this regimen. And this decision is, well, first of all, this is really an expert opinion in terms of 12 to 18 months. But in patients who are responding well at Ward 94, they're monitored really closely. And there's a look for sputum culture conversion with regular monitoring. The nursing staff is really fantastic about follow-up with patients. And as clinicians, we're following patients with routine radiographic monitoring as well to look for treatment response. And so 9 months is often used, and outcomes have been fantastic, as I had heard from personal communication from Janice Louie here in the audience. All right, so this patient was initiated on TB treatment with rifabutin, EMB, and levofloxacin. He's tolerating it now and doing okay. So when would you start this patient on antiretroviral therapy? The options are the same day you start TB treatment, within 2 weeks of TB treatment, within 8 weeks of TB treatment, or after completing 9 months of TB treatment. Great. So I'm going to present some data that are not new. This is more maybe seeing if our clinicians are up to date, and also just to go over a couple things. So I'll just say that within 2 weeks of TB treatment is, I think, the right answer here. The same day may be challenging if you're really worried about drug-drug interactions, and more importantly than that, really, is just understanding tolerability of the TB regimen. Within 8 weeks of TB treatment, I would argue you don't need to do. You could do within 2 weeks, and we want to get this patient on ART as soon as possible. So let's go through why. So these are, as I mentioned, are not new data, but the timing of antiretroviral therapy in patients with non-CNS TB disease, the evidence is very clear. So I'll just briefly walk through, and this slide is courtesy of Annie Lukemeier. But the first study, it was called SAPIT, and it looked at waiting until after TB treatment, which is called sequential, or 39 weeks. You get through your 6 weeks, versus integrated, meaning offering ART during TB treatment and just navigating drug-drug interactions with the rifamycins. This is in South Africa. And it's very clear that if you waited till after TB treatment, people die. So the mortality was much higher in the sequential arm, and that is not a reasonable strategy. I'm glad no one chose that. The subsequent 3 studies were the subgroup study from SAPIT that looked at early versus slightly more delayed or late TB treatment. And the goal here was to get through the 4-drug period of 8 weeks, and then when you're simplifying to isoniazid and rifampin to start ARVs. And they saw a reduction in mortality in the CD4 less than 50 group, with about a 2 to 3-fold increase in immune reconstitution syndrome. And the other 2 trials noted here, Camellia had a lower median CD4 than the others, saw a reduction of a third, so significant reduction in mortality with immediate ART. And then the ACTG, the STRIDE study with the first author of Diane Havlier, showed that immediate ART compared to early resulted in a significant reduction in mortality in the CD4 count less than 50 group, with an increase of iris 2-fold. The reason I think there's very little logic to consider even 8 weeks. If you look at a paper published by Annie Lukemeier from our division in JADES in 2014, the only group that really had a bump in iris risk was the CD4 count less than 50 who started ART within 2 weeks. And these are precisely the patients who survive. So you get a mortality benefit at the cost of a slight increase in iris. But worth noting, iris was not a fatal condition. So I hope the logic is clear here, but there's really no iris benefit of delaying for 8 weeks compared to starting immediately. The key points to walk away with are your increased risk of iris is higher, really driven by those with CD4 count less than 50, where you should 100% not wait to start ARVs. Most of the iris seen was really lymphadenopathy, some new or worsening infiltrates on chest X-ray, constitutional symptoms, and abdominal pain. And we see this commonly and know how to manage it. So, all right. Let's see, we're doing on time. Last question. So in general, and I get this question a lot, this is not specific to this patient, but in general, can you use BIC, so bictegravir or TAF, tenofovir alafenamide, with rifampin-based treatment? So your options are no. Rifampin lowers bictegravir and TAF levels. Gustavo showed a chart saying that, and you shouldn't give it. 2 is yes, we have sufficient data on BIC and TAF to provide this regimen to patients on rifampin. 3 is maybe. We have some new data from CROI that are encouraging, or I don't know. All right, we have good multiple choice takers. So. Okay. Great. So yes, I'm going to walk through some new data from CROI 2024. So this is the INSIGHT study, or the INSTIs for the management of HIV-associated TB, that looked at the efficacy, safety, and PK of BIC, F, TAF in adults with HIV and TB who were getting rifampicin or rifampin, and looked at 24-week outcomes. This was presented by Dr. Naidu at CROI 2024. And by way of background, in a healthy volunteer study that was presented at CROI 2018, rifampin does reduce BIC concentrations by about 60 to 80%. Though in general, the C trough remains above an inhibitory quotient. So they put together the CAPRISA 093 Insight study. This is what was newly presented, not yet published, that I've seen, which is a randomized controlled trial that enrolled adults with HIV and a CD4 count above 50, EGFR over 60, who were Hep B antigen negative, had RIF susceptible TB. And they were either ART naive or had been off ARVs for at least 3 months, all from South Africa. And they randomized 122 adults in a 2-to-1 ratio to either twice daily BIC FTAF, so given once in the morning, once in the evening, or once daily DTG 3TC TDF, which is really the global standard for generic ARVs and what's used in PEPFAR-funded countries like TLD, along with an evening dose of just monotherapy with dolutegravir, so twice a day dolutegravir, which is what's indicated with rifampin. And the primary endpoint was HIV RNA less than 50 copies per ml at week 24. Here's the study design. And this is what they found. Overall, the BIC arm characteristics and the dolutegravir arm characteristics are shown here, about a third female in BIC versus 40% in dolutegravir, similar median viral loads and median CD4. And the median time from TB to ART start was about the same, about 2 weeks. The BIC arm in the FDA snapshot analysis was 95% viral suppression at week 24 with no treatment failures. And if you look at the per protocol analysis, it was 97% of both arms. In terms of severe adverse events, it was 11% in the BIC arm versus 7% in the dolutegravir arm. And PK analyses are pending and were presented briefly in terms of BIC at CROI, but TAF not presented. So looking forward to those. In terms of this case subsequent course, the patient was started on abacavir 3TC and dolutegravir after testing HLA-B5701 negative and given entecavir for the hepatitis B within 2 weeks of TB treatment start. And he was started, as noted, on rifabutin, EMB, and levo. The sputum TB cultures were negative 2 weeks into TB treatment. However, the patient, and this is just weighing the risks, I think, of the different rifamycins, was developed thrombocytopenia and leukopenia on the rifabutin around 8 weeks into TB treatment. Then ended up completing a course on rifampin, EMB, and levo, and tolerated it quite well, actually, with no issue around transaminitis or other tolerability issues, and completed his TB treatment after 9 months. And now, several years later, is doing well clinically, with no evidence of recurrent TB. There was no evidence of iris. His HIV viral load is undetectable, and it was within 8 weeks of ART initiation, and several years later is now on BIC FTAF with appropriate drop in Hep B DNA and ongoing monitoring. So in summary, patients with advanced HIV are at higher risk for disseminated TB disease, along with TB in general, and including miliary TB. And patients with HIV and pulmonary TB with very low CD4 counts, this case is a reminder, have an increased likelihood of normal chest X-ray presentation. Hepatotoxicity is a common adverse effect of INH and PZA, and to a lesser extent, rifamycins, although it does occur, and liver-sparing TB treatment regimens should be considered in patients with active TB and liver disease, including our patients with HIV. The risk of DILI, or drug-induced liver injury, is higher in patients with TB-HIV co-infection. And just a reminder to everyone, and I think people know this, but prompt initiation of ART in people with HIV and TB is crucial to lower mortality and should be initiated within 2 weeks of TB treatment, in my opinion, in all. And we continue to learn more about the use of relatively newer antiretrovirals and rifamycins, with more to come. So I think we're moving in a direction of having a broader array of tools for HIV and TB co-treatment. I just want to thank both the Ward 86 and Ward 94 TB clinic providers and staff. It's really, I think, for Gustavo, myself, and others, a real privilege to be able to work at the 2 clinics. They're incredibly well-run clinics and co-located, really a model of integrated care and communication with one another. It's an absolute pleasure. So thank you all. And a quick thank you to Rebecca Abelman as well, who has shared some notes on this patient. Thanks.
Thank you both so much. That was great. Those are great cases. We'll start with the audience. Are there any questions from you all?
Thanks for a great presentation, Gabe and Gustavo. I have a question about the BIC-TAF FTC data and what you think about some of the observational data and using 3HP and 1HP with BIC-TAF FTC.
Great, thanks, Rebecca. The question I think everyone heard, but is what about using BIC, FTC, and TAF with 3HP or 1HP? You know, there are data, that's I think what you're alluding to, that have been published now in CID from Taiwan, where they went ahead and moved forward with recommendations to use 1HP and 3HP, and have been doing that in patients who are on Biktarvy, excuse me, as well as on dolutegravir-based regimens. And they have not been seeing any real issues with viral suppression. Annie and I actually wrote an op-ed in CID I may point you to. I can go through some of the points, but there are some limitations to the study data that presented. They were generally I think all patients who were already on antiretroviral therapy and suppressed. So if you give someone a 1-month regimen that might interfere with their viral suppression once daily, Biktarvy, which is what they did, I think the likelihood of seeing viral failure is low. But that might be different in someone coming in like this patient with a viral load greater than 10 million, where you're starting, you know, daily Biktarvy. I think you are putting someone potentially at risk for viral failure without more data. We know now that you can do daily, of course, dolutegravir with 3HP. So has tended to be my preference. We also are lacking really good PK data on TAF. What we do know is that TAF levels drop with rifapentine, which is really the cornerstone of these treatment shortening regimens for latent TB. And although the TAF serum levels drop, it actually, tenofovir levels within the cell are actually higher with TAF and rifampin than they are in TDF monotherapy, if that makes sense. So I think we're going to see that TAF is just fine and that Biktarvy is fine probably, but I think we, at this point, need more data. Those are observational data, select patients. There was some data presented at IS 2024 that looked at some of the issues I had raised in that op-ed, such as people starting ARVs, and again saw good rates of viral suppression. The other thing I'll point out in the published data is that the viral loads they looked at were a year later. So whether or not there's some low-level, you know, viremia that's occurring, it wasn't measured. So I think there's still some unknowns, and I tend to take a more conservative tack, and knowing the patient's life is going to be living with HIV at this point until we have a cure. So I tend to err on the side of caution.
I'll ask a quick related question about LTBI and then go to the chat. For either of you, you mentioned that Dr. Velásquez mentions that rifabutin is not guideline recommended for LTBI, but we have a reasonable amount of experience at 494 using rifabutin in this context. Just curious whether there are retrospective data from our center or others about progression to active TB for rifabutin versus
rifabutin in particular.
Yeah.
Well, I mean, shout out to Matt Hickey. There was one paper on rifabutin in liver transplant for treatment of LTBI, and there are a couple of series, but not anything comparative or very long term that I would. Yeah, that would hang my hat on.
Excellent. Thank you.
But shout out to
go, Dr. Hickey. There is a great question in the chat. Referencing people living with HIV who have miliary TB and cirrhosis. If they ask if patients had child's B or C cirrhosis, is there any context in which you dose reduce your anti-tuberculosis meds, and is there a role for checking drug levels?
Both answers,
yeah.
I guess. But I guess my first point would be, I think no on the lowering the drug levels. So certainly. No on reducing the dose. You want to effectively treat TB. I mean, miliary TB is essentially thought as universally fatal without treatment. So you don't want to compromise the TB therapy. And I think what was shown is you can pick regimens that are really quite liver sparing and monitor intensively, although obviously stressful. The second follow-up question of drug level monitoring, I think is a great question. Is something that I know the TB clinic led by Janice Louie, they're looking increasingly at levels and using those to guide therapy and potentially bumping the dose of drugs like rifampin, for example, if levels are coming in at a subtherapeutic point. I think how to interpret those is still some kind of an ongoing field of inquiry, but maybe Gustavo could comment on that as well.
Yeah, no, thanks. Exactly. I think if there are comorbid conditions, the guidelines say, you know, for some conditions, like for example, diabetes and others, you can consider therapeutic drug monitoring. I think we tend to be even perhaps more aggressive than that. And I think in just like Gabe was saying, that in this particular situation with miliary TB, it is a more severe presentation. So you are actually quite kind of more aggressive about treating the TB. Thanks.